I want to first thank the organizers and especially Dr. Parmar for inviting me to this very exciting meeting and for talking about some of the things that we are doing at MD Anderson in this talk. So, we already heard from Dr. Moti about the advent of stem cell transplantation for high-risk MDS. I will limit my comments to the high-risk group, and I will stay away from talking about the pediatric patient population as well, because I don't know anything about pediatric transplantation. I'm an adult. I started my career as a child, but that's before I went into medicine. So the review that we have made is primarily the work of Dr. Oran and Dr. Kong Tim in our group, and I'm going to talk about their data today. But several other people have contributed, as is common for clinical studies. It's not really my work. Now, as we already heard, allogeneic transplant can lead to long-term complete remissions and potentially cure in intermediate and high-risk MDS, and we have limited our work primarily to the intermediate 2 and the high-risk patient categories who rapidly progress either into complete marrow failure with secondary complications of marrow failure or progress into AML. Many of these patients have cytogenetic abnormalities, and increasing blast counts may indicate a poor prognosis, as Dr. Moti just reviewed. And therefore, cytogenetic normalization through cytoreductive therapy is often felt to be indicated. The question here was the timing of transplant. And this is a slide from the CIBMTR. And it basically shows that early transplant is better than late transplant. So the timing, early versus late, that's the question. Can I leave now, Simrit? No. Okay, so we thought we would dwell a little bit more into detail because these IBMTR reviews are, of course, limited by a lot of heterogeneity between different treatment centers, different patients, subpopulations, different conditioning therapies, etc. So we limited our review to patients treated at MD Anderson only, and our objective was to determine if there were prognostic factors for overall and event-free survival after transplant, focusing in on things that had been reported before, primarily both in conventional leukemia therapy and in transplant, to have an impact on outcomes, such as cytogenetics and remission status secondary to previous therapy. And then the optimal timing of transplant. Do you want to treat in a remission, or do you want to treat with transplant instead of hypomethylating or intensive chemotherapy? And the secondary objective was to find prognostic factor to determine the risk of relapse and treatment-related mortality, such that we can possibly help us stay clear or take extra precaution if there is an excessively high risk based on predetermined features in an individual patient, thus impacting the decision whether to recommend transplant or not. Overall, we reviewed clinical data from close to 300 MDS patients, excluding patients who had already progressed into AML at the time of transplant. And this was the first allogeneic transplant. This is between January of 2001 through December 31 of 2011. Only adults, and patients were characterized based on the pre-transplant therapy. Therefore, if they had been untreated when they came to transplant, whether they had had chemotherapy alone as a major subgroup, whether they had received hypomethylating agent therapy alone, or whether they had a combination thereof. And as you can see, there are some differences between the groups the subgroups, such that, for instance, we did not have a very high subfraction of CMML patients among the untreated who went straight to transplant, and CMML is, at least in our experience, a poor prognosis factor in its own right for patients. And we had a very high proportion, 60% of patients in the untreated group who came to transplant directly were patients who had a treatment-related MDS after therapy for a previous malignancy. Other than that, the groups were fairly well balanced. When it came to clinical parameters, the platelet count is highest in those patients who have received hypomethylating therapy, signaling a response to that treatment when they come to transplant. But other than that, there is no significant trend for any difference clinically. And when it came to more advanced patients, the 70 to 80% of the patients have more advanced disease than being in remission. So this is truly a high-risk group overall when we think about it. Cytogenetic remission at time of transplant was only found in a minority in each subgroup that came to transplant. When it came to timing, it's striking that the majority of patients, of course, who had chemotherapy with hypomethylating agents or hypomethylating agents alone were transplanted in the later part. Sorry for this, there is a timer built in here. Have been transplanted in the later part of the review, possibly somewhat biasing for outcome against the patients who went straight to transplant. Further, when it comes to the conditioning regimens, this is fraught with a little bit of the same problem as the IBM-TR reviews, namely that we have treated with nucleoside analog alkylating agent combinations. However, it's fludarabine melphalan at 3 to 4 different dose levels, and it is fludarabine busulfan, intravenous busulfan, used either as fixed dose busulfan at 3 different dose levels or pharmacokinetically directed busulfan at 2 different dose levels. So there is a little bit of caution there, and if we have time at the end, I will show you how that can impact the interpretation of some of the outcomes. The overall and event-free survival for the whole group is around 35 to 35% at 3 to 5 years, and overall survival 32 to 38% at 3 to 5 years. And if we look at the event-free survival by karyotypic abnormalities, patients who had a normal karyotype have done the best. 3-year survival event-free of 56% overall, which is fairly good. Those who had a karyotypic abnormality, including a -7 or a 7q minus, are down to 33%, are down to 10%. With -7 or 7q minus, and for those who have a complex karyotypic abnormality but excluding chromosome 7, they are in between, around 33% at 3 years. So karyotype came out as a quite significant prognostic indicator for what will happen post-transplant. When it came to previous therapy, we find to our surprise that those patients who were untreated have been doing the best, with an event-free survival at 3 years of 43%, whereas patients who had either chemotherapy alone or chemotherapy plus a hypermethylating agent combination in the background had a 3-year survival of 31%, and for those who had hypomethylating agents alone, we're down to 31% as well, but further decreasing out till 5 years. And for patients with active disease, untreated, whether they have active disease, CR, or untreated, again, untreated patients strikingly did better than those even who had obtained a previous CR. who did only marginally better than those with active disease at the time to transplant. So we interpreted that prior therapy actually increased the risk for adverse events and decreased the chance for a successful outcome. Being in CR in our hands was not a significant improvement. Dr. Moti suggested that it's better to site reduce. Conventional wisdom will say so. I would agree with him, but it's a little bit hard for me to completely say that there may be something to taking patients straight to transplant. Our data do not support an aggressive attempt at keeping patients on a longer term or an extended time of hypomethylating agents or chemotherapy before they come to transplant. And when we look at therapy and response in the high and very high subgroup only, again, the untreated patients come out the best at 40% event-free survival at 3 years. Patients in CR or with active disease come out at about the same, roughly half the 3-year event-free survival of those patients who are untreated. In a multivariate model, the megakaryotypic picture has a major impact. Those to predict for relapse post-transplant. The relapse incidence was about 16% for patients who went into transplant and had a history of normal karyotype, whereas those with aberrations excluding monosomy 7 or 7q- were around 23% overall, whereas those with abnormalities including monosomy 7 or 7q- come out to be very high risk for progressive disease with a risk of over 55% at 2 years. And finally, the choice of donor, whether we have a match-related donor, MUD, or mismatched donor, also increased the risk for treatment-related mortality, such that an unrelated donor was a higher risk situation for serious complications than matched completely related donors. And this has been adjusted for response to previous therapy and to the ferritin level, which is also, as we heard from Dr. Kornblau, of some importance for the risk. So to summarize this, high-risk cytogenetic abnormalities at diagnosis influence the patient's prognosis after transplant. That can be considered confirmed. Treatment with chemotherapy or hypomethylating agents led to a similar post-transplant outcome, regardless of the choice of pre-therapy. However, response to hypomethylating agents or chemotherapy did not predict a better outcome after the allogeneic transplant, and the best long-term outcome, again, was seen with early allocation of transplant. So our results raise a question about the value of cytoreductive or hypomethylating agent therapy prior to transplant. I'm not going to say that we don't want to see it, but it raises a question as to whether controlled clinical studies should really be performed in that area. And we currently recommend early stem cell transplantation without previous therapy, trying to site reduce, unless there are comorbidities that necessitate the stabilization of the overall situation. And instead, we recommend to go straight to transplant for intermediate to and high-risk patients. And I think we have a couple of minutes. So I will give you an example of factors that may be confounding for transplant for MDS. And that has to do with a non-standardized conditioning therapy. As we all probably have seen before, there is a general trend that increasing intensity leads to increasing treatment-related mortality. That trend has been broken with a nucleoside analog alkylating agent introduction. and one can now dose intensify without increasing the risk for treatment-related mortality significantly. Our standard regimen, as previously published by Dr. De Lima, who sits here in the second row, was that of 4 days of fludarabine at 40 milligram per meter each, followed by a dose of IV busulfan given over 3 hours, and after these 4 days, 2 rest days. Rabbit ATG for patients who received a one antigen mismatched or unrelated donor transplant, and then take them to transplant. Now, this is our standard regimen. It was varied through the hypothesis that pharmacokinetically guided delivery of IV busulfan when given with fludarabine would provide an improved outcome after allogeneic stem cell transplantation for AML and MDS. And we based that, we can also say that there is a therapeutic window. We depict the therapeutic window here as a compromise between the attempt at controlling leukemia, which is easier for patients in remission versus those in a phase of active disease. The compromise is that if you increase the intensity, you run into normal organ toxicity and graft versus host disease. We hypothesized that you can dose intensify, which is the narrow, high, light blue, this one, versus fixed dosing, which gives a wider range in systemic exposure. They both come up to about the same maximum systemic exposure, and therefore the whole group, on average, in the pharmacokinetically dose-guided program, will receive a more intense treatment. We hypothesized that you can dose intensify by about 20% and give a median area under curve or dose intensity of 6,000 micromolar a minute daily for 4 days, which is a 20% increase over the average of fixed dose of 130 per meter. And if we go straight to MDS, as you can see, the PK-adjusted group has a 5-year event-free survival of about 52%, whereas the fixed dosing group of MDS patients had an event-free survival of only about 28%, meaning that almost a doubling of event-free survival at 3 to 5 years. Further, there is no increase in early mortality between these two groups. There's no difference, none whatsoever in the first 6 months, except that there is a faster drop-off with more early relapses in the fixed dosing arm. It's a small number of patients, only 25 patients in each arm, but these have been properly randomized and stratified and are fully comparable. So, again, patients who got the best outcome were those who went straight to transplant. And we recommend early transplant for intermediate and high-risk MDS patients, awaiting further clinical studies of the value of alternative treatment before taking them to transplant. But these studies have to be very carefully designed, and it's also important to remember that the outcome of the transplant itself is best served by controlling the conditioning and every little aspect of the transplant procedure itself. And as I depicted here, even a small change in one variable can make a major change in impact over time. Thank you very much for your attention.
Thank you, Dr. Andersson, for your very instructive lecture.